Thank you, Dr. Dukas. I come from Rhode Island. Any Rhode Islanders here? Okay, so that's good. They rarely get out. But Rhode Island is it's a state of one. 1 million people, 1 hour at every corner, one city, one medical school, one department of whatever you have, and wherever you go, you see the same 100 people. And you'll only be here for a while because all Rhode Islanders tend to come home. So it's a place that people return to multiple generations. But I'm thrilled to be here. I've been to Louisville before. I think it was 35 or 40 years ago, and the city's changed a lot. But then, so we're going to be talking about medical errors. We'll talk more about them if I can figure out how to use your... There we go. Okay, so the goals, we're going to look at the issues of medical mistakes, including deaths caused by errors, exploring our own roles in that, both individual and group roles, the consequences of causing serious harm to patients, the repercussions, and then finally going to suggest some methods for preventing and coping, including the use of narrative. I'd love to get the audience involved, so there are these questionnaires which are totally anonymous, will not be used for research, but there'll be a point in a few minutes to hand them up to Dr. Dukas, who will dutifully collate them and will present the results. Just in the room, how many people are students? Okay, how many are first-year students? Second-year students? Any third or fourth? Okay, a few in there. Any residents in the room? Okay, fellows, faculty, nursing faculty or nurses? Any social workers, psychologists, lawyers, and then the... okay, so we'll try to reach out the whole audience. Number one, mistakes are really part of our lives. I think that's really the starting point. We're going to talk about what are they, why are they so difficult for us to make, handle, and overcome, some examples, and then some possible approaches for the practitioner for others. We'll give the results of the questionnaires summate, and then I understand that this is a group that likes to talk about it, so we'll leave some time for that and questions. So the first question is, who did you kill this week? This is something we don't talk about. We didn't go into medicine or nursing, psychology, or even the law to kill people, yet most every physician has his or her graveyard. It's something which I'll start with me, and I'm going to use examples today from myself. I have my own graveyard. If you talk to any physician who's been out for a while, more than a year or two, they have their graveyard, particularly during the time of training. Cognitive dissonance is involved in that, so often people don't remember it. But if you search well enough, if they've been in practice long enough, treated enough patients, they've killed people. The second question is, number one, who did you kill? And we won't really go into that. When will you be sued? So there's different figures out there for the risk after seeing X number of patients. One of it is if you see 40,000 patients in family medicine, you'd be sued at least once. There's others that say, well, 1 in 4 physicians are sued every year. You can find in the literature for different procedures that you perform the risk of being sued and the changes that have happened over the last 10, 20, or 30 years. But there is a real risk. And part of this, as an anthropologist, we get into, well, this is a very odd system. I've worked in other countries, many other countries, and in a lot of places you'll get a mean letter. One of the places I worked, they'd turn over your desk or break your arm. But the U.S., it's about being sued. It's about culpability, responsibility. And that gets into, and we won't go into this in any depth, but sort of Western notions of responsibility. Our society is built in a fairly linear fashion in that manner. There's cause and there's effect. That varies with other cultures that might deal with issues of fate, that things are fated to be, so why would you sue anyone? It's part of your fate. Or what's popular, certainly I'm sure in Louisville and around the country, around the world, complexity theory, which is there's no simple linear explanation for things. But in our society we see that, and it's part of what influences us in terms of medical errors. So, and I'm sure this is a very smart group, and I'm sure the students are particularly smart, but being smart is not good enough, and that was one piece I wanted just to kind of rule out at the beginning. In fact, there was a study showing that in Florida, at least, that the smarter the doctors in terms of medical knowledge, the more they got sued. And they checked on several different parameters: specialty board certification, recognition awards, even being alpha, omega, alpha. You have an AOA chapter here. So if you're going to be omega alpha, your chance of getting sued is higher. So clearly, just knowledge isn't enough to avoid errors.
You care to comment on that last part about being certified or being ARA?
Oh, why that might be? Well, maybe a little bit later on, but I think that part of it is it's about the nature of errors and the possibility of errors, and also perhaps the nature of practice, that practice does involve errors. There may be a certain error, that is, if you know more, you may communicate less, but I don't think they've actually looked into the reasons why that might be. What they have looked into, and this is, I'm sure all of you are familiar with, To Err is Human, the Institute of Medicine report, that as many as really 100,000 people die in any given year from medical errors that occur in hospitals. Now, this was a shocking number that came out. Then there's some debate about the number, but it's clear, and anyone who works in a hospital knows, a lot of people die not just from being in the hospital, but in fact from what happens there. I remember being a student at Case Western in Cleveland and then in residency, and I was amazed at people who came in with one illness, that if the illness didn't get them, we'd kill them through our testing and sometimes through our treatments. That hospitals are toxic places. There's more deaths supposedly from what we do in hospitals, of course, than AIDS, accidents, breast cancer, issues that have a lot more focus. So this has become more of a focus. And as Dr. Dukas reminded me, there's actually 3 aspects of that report. One is that, of course, we need to recognize that we're doing errors and work on them. The other is the issue of professionalism that we need to increase. And that's something that we'll get into. And it's pretty well known, and this has been a focus and will likely become much more of a focus with our new Medicare boss, who's who's from the Institute of Health Quality Improvement, who will be coming in. But healthcare is not as safe as it should be. There's been various studies that 2.9% of hospitalizations, there were adverse effects. 6.6% of those led to death. In New York, 3.7% of hospitalizations, there were adverse events. 13.6% lead to death. I guess the message there is if you're going to get hospitalized, do it in Colorado or Utah. But in general, about half the errors could be corrected. And the numbers keep growing. This was a study that came out after the Institute of Medicine study that not 100,000, nearly 200,000 died of preventable in-hospital medical errors. This was a study of 37 million patient records. So the angel of death is out there hovering and flies through all the rooms as we're watching. And just to be certain, because I'm a family doctor as well, this is not just in the hospital. We're doing lots of errors in the outpatient setting as well. So they looked at 15 physicians in 7 practices who completed forms, themselves completed on 351 outpatient visits. They found that errors and preventable adverse events were identified in 24% of these visits. Now, often they were considered often administration errors, but 24% of visits. And they thought of those errors that occurred, 24% resulted in harm to patients, and potentially harm in another 70%. So 24% of visits, and perhaps 94% of those times when that there was an adverse event, it caused harm to patients. And what was interesting as well is that when you asked physicians after each encounter, was there any error as part of that encounter, it varied from 3 to 60% of visits. So the issue of errors is not just we're doing them, it's also are we identifying them. And what I'll mostly spend the time talking about is what are we doing after we identify them. But clearly, as I mentioned in the beginning, we all have our graveyards. Well, we don't talk about it, we don't look at it. When we make mistakes, we're not out there as students, as residents, as faculty, as nurses, as psychologists. We're not there to make mistakes. So it's one of the pieces that often drops by the wayside. We start to forget it. And it's not just family doctors. You can go in field after field and find that mistakes are being done. So this was about general internists and medical subspecialists. So the ubiquity of errors, of mistakes in clinical practice. And the second one, the infrequency of self-disclosure. We don't tell people. When we make mistakes, we don't tell our friends. We often don't tell the patient. Even with the movement now towards apology, we try to hide it. We try to seal it. It often comes out in other ways, but it hasn't been something that we've dealt with well. And I should say, for disclosure, one of the reasons I started to do this talk was when I was part of a residency program overseas, there was a lot of errors happening with the residents, as happened in all residency programs, and there was no mechanism to talk about it. So starting with the chair, every senior faculty member had to talk about their errors to try to generalize the experience, to normalize the experience. We're not trying to become the airline industry, but we're trying to have a mechanism by which we can identify our errors, deal with our errors, and move on. Because this has, and I think just the last point, next to last point, this has a lot of impact on the physician and on any provider. Some mistakes were remembered years in details, and as we'll get into, change careers. The severity of the stress may be influenced by factors such as prior beliefs and perfectionism. Well, I imagine all of you in healthcare have a little bit of perfectionism. And just one story, one of the sadder stories, and this comes time and time again, was having a conversation with a physician in Rhode Island, OBGYN. Talked to him about, well, I said, do you still do deliveries? He said, oh no, I don't do deliveries anymore. I said, well, why not? And I said, well, I finished residency, finished fellowship, was in practice, and I was on New Year's Eve, and a father really wanted the baby to be born in the year before the next year, because he wanted the tax break on it. And I was young, I didn't know, I thought, well, it might be a reasonable thing to do. Induced the mother, we're working on it, the hours are working down. He said, can't you do anything? So he did interventions that unfortunately resulted in a bad outcome. That was the end of his OB career. Now, if you think about it, 4 years of undergrad, 4 years of medical school, 4 to 5 years of OBGYN residency, fellowship, over, done, in one event that he never talked about. This is now 35 years later. So it's everywhere and it matters. This is that chance, the questionnaires, if you have them and you fill them out, if you could just pass them over to Dr. Dukas. We'll just take a second. And once again, they are anonymous questionnaires. They will be destroyed after this. Dr. Dukas will shuffle them and then burn them. And we'll present the results at the end of this talk, if Dr. Dukas can collate them quickly enough. Any questions on this, by the way? This is just, I want you to work a little bit and kind of reach back and see, to give a sense of what you've learned and what you've done. Okay, a few examples. The cocky sub-intern. This happened at a medium-sized, now large medical center in the East Coast in Boston. I had come from Cleveland. I had inserted some duodenal feeding tubes a few times, and so I thought, hey, I can do anything. It was an older gentleman who didn't have a very good gag reflex. The intern and the resident were having a hard time. He said, oh, let me do it. And at the time, for any of you who put in duodenal feeding tubes or feeding tubes, they often have a guide wire. And the guide wires now are blunted and usually made of at least the end has a tip. At the time, there was no tip. It was just a metal wire that was pretty razor sharp at the end. So I was a cocky person. I said, oh, let me just do it. What's wrong with this picture? Someone who said, oh no, you want to say? X-ray requisition asked to check the tube placement. There was a nasogastric tube properly positioned in the stomach, so this is the nasogastric tube. But the feeding tube passed through the bronchial tree of the right lower lobe and extended well into the right pleural space. You don't want a catheter there. In fact, the one that I put in went further down and actually ended up at the same place as the nasogastric tube. So it had punctured through the lung and gone into the pleural space and looked like it was in the same space. And we were getting ready to do what would have been really disastrous, which was put in some fluid, put in some feeding fluid through it, when someone said, that doesn't look quite right, and they did a lateral and found that it was in the wrong place. So what was the reaction? The medical team, they were like, wow, let's publish it, this is great. The attending didn't even know about it, was never told. And this was the old Boston City days, if anyone knows Boston City, where residents ruled and students ruled, and there really was no attending around anyway. What was my reaction? Where can I climb under a rock? I was horrified. And how about the patient? He died. Fast forward another 15 years, I'm in a busy day in the clinic, and this was 27 patients were scheduled for the morning, which was a pretty busy clinic morning, and my partner didn't come in. So we are just pushing through the patients as fast as we can, myself and a nurse. In walks a kind of disheveled older woman, not our patient. This was I was working in southern Israel at the time in the port city, and it was like the British system where we had a list of patients. So we knew who were our 1,500 patients per provider. This wasn't one of them. She arrived with her daughter. I did an initial brief history and physical. It was a woman who did a few tests, got some orthostatic BPs. Argentinian, I spoke English, Hebrew, and Arabic. She spoke Spanish, which I didn't speak. Daughter was only there for a little while and had to leave. We got some sense that she had some diabetes. It wasn't terribly controlled. Had some mental illness. Maybe she was schizophrenic, also not entirely clear. But had this abdominal pain, diarrhea, vomiting. Not clear what she'd had, but as it came through, someone mentioned she might have had some liver pate the night before. We thought, oh, okay. Liver pate the night before, nausea, diarrhea, some pains everywhere. Couldn't really communicate well. We didn't know or didn't have her medical record. Did a brief physical exam, elderly, pale, unkept, dry mucous membranes, abdomen was non-distended, a little bit tender, particularly in the left upper quadrant, no rebound. Did some vitals, temperature, vitals showed that she was orthostatic, so her blood pressure fell when she stood up. So, and then saw that glucose was up a little bit. Urinalysis was showing that she was a little bit dry. Specific gravity showing that she was particularly dry. So she hadn't had much fluid. She was having some nausea and vomiting. Maybe had this liver pate. I was running around seeing patients in several different rooms. Diagnosis was... Students, what was the diagnosis? What does it sound like?
Dehydration.
Dehydration, okay. Due to?
Diabetes.
Okay, that's one possibility. Good possibility. Diarrhea, probably a little GI illness. I thought, GI illness, let's do that. Let's go there. So the timeline was, arrived in with her daughter at 9 a.m. I reviewed the results at 9:30. I thought, this is a woman with gastroenteritis, a little bit of stomach bug. Diabetes had probably worsened it. Let's give her some fluid. I put in the IV myself. We had a kind of an area for treating patients but it was a busy day, so we took the screen and covered over where she was getting it. I said, give her it slowly, but I didn't really monitor how much fluid she was getting. And about 10:30, just as we're getting to this is happening, the other daughter comes in, and this daughter speaks Hebrew very well. We're communicating. She starts to give a different story, slightly different story. Different kinds of pains, may have had some shortness of breath, maybe a little bit of chest pain, but I had already figured out what this woman had. I was giving fluid, need to move on. So I somewhat discounted. I had done what's called premature closure of the story. We opened the screen at about 11 o'clock. There is a blue patient there who is short of breath. This is bad. Also, I look at the amount of IV fluid that's gone through. Nearly a whole liter has gone through of normal saline. So at that point, we say, oh, shit. Start emergency measures. This is do an EKG. Those of you who don't read EKGs, let's just say there's lots of abnormalities there that indicate something is going on with the heart. Ischemia is being present in several leads. Maybe this had started out as GI, maybe not. But the woman was having, what was she having? Well, she's having a heart attack, inferior, which is probably irritating part of the stomach, because the heart is right above there, so she's having some GI symptoms due to that. This was not gastroenteritis from liver pate. This was an MI, which worsened over time. Rescue arrives to take the patient to the emergency room, or moved from the emergency department to the intensive care unit at 12 o'clock. 12:30 intubation. That evening, fatal arrhythmia and death. Pulseless electrical activity. So, this was not good. What were the responses? The ICU attending, because I was certainly horrified at what I had done, said, well, this happens, which I thought was very interesting, and we'll kind of come back to that. My partner, who had been away the day, was sympathetic. The family actually asked, why didn't you know? Some of you may know, and it's something that I lived in Israel for a long time, lots of mourning practices after death. Each ethnic group has its own. This group was Sephardic Jewish. They do 7 days of mourning where they basically sit on the floor, no mirrors, no bathing. People come and visit. I decided to kind of go there, to kind of face up to what had happened. This was before the age of, which is now to ask for an apology, but basically to say, had made an error, need to deal with it. So went to the family, sat on the floor. You're supposed, the tradition is that you don't speak until spoken to. So received a lot of pretty hard messages from the family, but I think that was able to have a dialogue, and I think they were very pleased that I came. But still a lot of guilt and doubt. Interestingly enough, and I'll go back to this ICU attending, some of the first mea culpas in the medical literature was done by a guy named Hilfinger, who was from the Northeast, who wrote about an event that he had had with, he thought that he was evacuating a uterus of a woman who had gone through a spontaneous abortion, and in fact had an error and was actually performing an abortion when on someone that he was not meant to perform one on, and it would turn out to be a friend. And this he wrote into, I think it was the New England Journal of Medicine. And at the time, this was, I think, in the 70s, late 70s, received scathing diatribes in the published literature and also in professional societies at the time, that how could he do this? So I think that at the beginning of the time when people talked about their errors, medicine has not been so forgiving. So I think that I was actually able to have an experience that clearly made an error, had some support from the medical staff, could go on. And I think, as you probably know, there's a huge literature on errors and common illnesses, MIs being one of them, and there's lots of preventable deaths from myocardial infarction, which is why, in many ways, having come back to this country, I see that, and I don't know if it's that way in Louisville, that anybody with chest pain of any type gets admitted. It certainly happens in the Providence area. I don't know if it happens around here. And in part because people are so nervous about missing an MI. But the reality is, if you see enough patients, you're going to miss it, because it works on ratios. Sometimes you're going to make errors. So why is it so difficult for us? Why, I gave the example of someone who was raked over the coals for the errors that they do. We don't talk about it. Has anyone else been to a lecture where their attendings talk about their errors? M&M. Okay, so M&M rounds, morbidity and mortality, I imagine they have those here, are some of the areas. Sometimes it's a little bit sanitized, but that's an area where some can talk about errors. But it doesn't fit in with why we become doctors. It doesn't fit in with our training. And I think most folks deal with, if you don't talk about it, it's going to go away. And it really doesn't fit in often with our social or collegial expectations. These are not the kind of stories that we tell to one another in the hallway, by and large. And this gets into the kind of the whole images. This is the anthropology of medicine. I don't know if there's a pointer. I don't see anything that looks like a pointer, but I'll use my fingers then. But there's various reasons why we went into medicine, nursing, psychology, and sometimes these are various models. The war, religious, family, technical, collegial, education, forensic. But let's say the war model. We're in there, this is the war against cancer, or the war against poverty, the war against something. We're the fighters, the patient is the battlefield on which that battle takes place. Maybe we go into it for religious convictions. We're the hand of God, where the role of the patient is to be the sheep or the person that we're helping through. The classic model, certainly in family medicine, was, and this was in the age of male physicians, was you had the father who was the doctor, you had the mother who was the nurse, and you had the child who was the patient. Maybe we're technical, and a lot of fields of medicine are technical, so we're technicians, and we're fixing these broken machines, bringing them back. Or there are, someone described this morning that all of our patients are friends and colleagues. That's the relationship we're going to be, and so we're developing that kind of relationship. We might be the educator, we might be the policeman, but in no ways are we the angel of death. So it doesn't fit in with any of these models of being someone who errs. The study in '96 showed that People really had needs to talk about their mistakes after they made them. 63% needed someone to talk to. People needed validation of their decision-making process and reaffirmation of their professional competence. And then gets even more basic stuff, reassurance that of their self-worth. This gets to the depth, and we'll talk a little bit more about that. So what do? The first thing you do if you make a mistake is probably take your pulse. And for some of you who are old enough, you read The House of God, and so that's what you do in a code or in any situation. But take your own pulse, see how you're feeling. Because whatever's happened to the patient has happened. How are you doing? The second thing you do, of course, and this gets into some of the medical legal, is you document fully. You never change the record. That, of course, hopefully is told for you from day one of medical school. But you add a full account. So whether you do that with your risk management department, you should probably tell her by yourself, you go back to the record and you write everything you can possibly remember about it in as much detail as you can possibly remember. We won't go into it now, but there are, of course, other ways that you want to deal with your malpractice carrier and various other ways. And then the next thing I suggest is go talk to a supportive colleague or your senior physician. To close family and friends. This is stuff that, depending on the degree of difficulty and discomfort that you have, may affect you down to your bones. So finding people to speak with about it and go over it is very important. We often deal in our professional life as physicians with a lot of people looking down their throats, the retrospectoscope, so that people always can see the picture more clearly after it happens. It's oftentimes, that's what we call the retrospectoscope. The retrospectoscope is always 20/20. But it's much more difficult to go point by point how you made a decision, if you made an error, where you might improve in the future. And I will come back to this again, but about consider writing. I'm a big supporter of narrative medicine, with the use of stories in medicine. But this is a great time to sit down and write your story with a lot of emotion, a lot of verve. You can come back to it. And just as we'll take a slight tangent onto that narrative in medicine. When you write down the story, you find meaning in events. When patients come to you in any shape or form, or family members, they tell you about their illness, they've put the pieces together in a way that creates some meaning. Each time you tell the story, it changes. So it changes by the number of times you've told it, and it changes by who you tell it to, which is why you always get students and residents who they'll go into the room, they'll get a long history from a patient, then the attending will come in and get something totally different, and the student will say, well, they told me the story, they changed their story. Well, of course they changed their story. It changes each time it's told, and it changes as they go through and make more meaning and find new pieces of it. But we use it in clinical education, research, self-care, professional growth and reflection, legal, social justice, and communal memory. Narratives are used in all kinds of ways, but this is one time when storytelling, story making, story writing is very powerful, when you make an error. So, as I mentioned, creates meaning from events, changes with the telling, have a motive and ritualistic functions. The process of telling a story turns out to be very calming, soothing, as well as it creates a sense of having a rational sense of what happened in events. And what we can do when we make errors is we can take some of that, we can harness it re-biography. In other words, we can change it into our story of ourselves and can be utilized in the healing process. And the story, for instance, often happens after major events like this, major errors, is people say, I'm a bad person, I'm a bad doctor, I shouldn't be in medicine. Or it'll become external. I externalize. I could have done something, but that, the operating room team was terrible that day. Or the lights in the emergency room weren't right. Or I got the wrong lab value because the lab wasn't correct. So there's a lot of stuff that we can use. If we put it down, we can actually deal with it, take it to someone else, consult with them about it, and use it ourselves. And there's three kinds of stories. Arthur Frank, who would be a good speaker to bring down from Canada, talks about the wounded healer. And basically, if you take medical stories, you can break them down into three. Some people, in terms of I don't know if there's any military people here, but in the military, everything's taught in threes. But the notion being, most of our stories are restitution stories. This is what we love to tell. This is what we tell in the hallways. This is what your attendings are going to mostly tell you, what you talk about to one another. They were sick. I did something. They got better. I did that surgery. A chance to cut is a chance to cure. I made a difference in the life of that patient. They were wrong, they're now right. Those are the ones we'd love to tell. And I did a book of medical narratives. About 98% of the medical narratives that are sent in are that kind of story. That's some of the error stories. You did something wrong, you intervened, you made it right. But the second kind is just as important, the quest story. This illness or an error becomes a condition from which something can be learned, something transformative, even if healing is not possible. And we'll get into this a little more perhaps in the questions, but that's probably the goal of the error story. In other words, you did something that caused harm to somebody else. We do that a lot in medicine. But did we learn something from it? Did the patient learn something from it? Did the family learn something from it? Did the students learn something from it? In some way, did it transform myself or the people around me? This is very common, of course, in cancer stories. The person had a bad cancer. They were a terrible person. As they got the cancer, faced death, they became a better person. Or the people around them learned about the importance of life or whatever, various stories. So the quest stories are the ones where someone gets transformed, even if the bad thing doesn't get made better. The ones we want to avoid are these, the chaos stories. There's no order or answers in a whirlpool of suffering. This is the kind of story where something bad happens, and then something worse happens, and the more you go into it, it's like circling the drain, goes down and down and down and down and down. And these are the people who leave medicine. I never forget, as a kid in Cleveland, Ohio, going to see a dermatologist, was talking to her, I said, well, I was interested in medicine. I said, what was your medical career? He said, well, I used to be an internist. I said, well, you're a dermatologist, aren't you? He said, yeah, I didn't like dealing with life and death. Clearly, that was somebody who had been scarred along the way, left that career, he was perhaps happy as a dermatologist, but left the career of his choosing because he was stuck in chaos. Okay, so next part is, after you've talked to colleagues, decide how to handle the consequences and be proactive. Particularly in family medicine, but in all fields of medicine, you're dealing through relationships, the doctor-patient relationship, the doctor-family relationship. Giving apologies turns out to be probably a very good thing to do. We won't go into that, but that's very much in vogue now, both in medicine and I think in human interaction. Whereas before, your risk manager or insurance company, malpractice insurance, would say, no, don't talk to the family. It's now, I think, pretty well accepted that it does not increase your rates of being sued, probably decreases it dramatically, to go out there and talk to the family, apologize for what you've done. But it's time to talk to your colleagues, the nursing staff, the insurers, the legal system, because there can be repercussions from what you've done. After you've dealt with the consequences, time to learn from the mistakes and improve systems. It turns out that some of the responses, and we'll talk about this in a minute, some of the responses to what do you learn has to do with, well, I'm just doing what I'm doing, but I'm going to do it better, which often is not the way to go about. So often we need to change the way we do things. Evaluate the impact on you personally. Consider counseling, considering CME, continuing medical education. It turns out there's some interesting data on people who've been sued that they often get depressed, leave medicine, and it doesn't depend on whether they won the case or lost the case, which I found to be fascinating. The process is so dystonic with who we are as professionals, it's very difficult to live with. Learn from the episode, and the number 8, which we'll talk about, is you got to move on. So take heart from your relationships. The patient-physician relationship is the foundation on which the adverse events occur. And this adverse event will be a stressor and will either undermine or strengthen the relationship. One can go on with families, individuals with whom you've made mistakes. It's kind of amazing that they can continue to be your patients. They can continue to work with you, in part if you're able to deal with the issue and deal in a manner that people feel satisfied. The actual management of the adverse event within the context will influence the ultimate course of events. So this is why that we always talk about the importance of forming good doctor-patient relationships, but it turns out that it is the basis on which to deal with both good things and bad things. I was always afraid when I worked in these small communities, when I was a rural doc, you make one big mistake and you're out. And I'd seen that happen for not just for doctors, but for clergy, for teachers. And eventually you're going to make a big mistake, I realized. So we did a study of this, and it turns out that in certain countries, like in the U.S., people grow to love their rural doctors. They tend not to kick them out. In other countries, there's almost a lifespan that you know that within 4 to 10 years you'll be gone, because eventually you'll make enough, piss off enough people that you won't be able to exist in the community. And it actually exists for multiple professions. So having the ability to work through that, form relationships where there's the understanding, is critically important. These are just some of the common reasons that doctors get sued. I won't go into that. I realized that it may have been 3 or 4, but this was from Roberts. What are the 3 big things that you need to manage them? Well, you need compassion, communication, and competence. What's the 4th C? Well, it's not cover your rear end. That's really not part of it. But it's about, can you have compassion, can you communicate, and you need to be competent medically. So I wanted just to talk a minute. Part of the aspect is doing better after you make errors. So how do you do better? Well, this was a study of 416 error reports by U.S. family physicians. Usually it's about ordering medications, implementing medication orders, implementing laboratory investigations, responding to abnormal laboratory tests, filing forms, and maintaining patient records. Well, one way you can do it is by just improving the system so you don't have as many difficulties with that. 1.5 million people harmed every year from medication errors. What we did in our family practice is, as many others have, is we went from paper copies to electronic copies. We still make errors, but boy, do we make a lot less errors than we used to. Not to mention, how many of you use electronic health records? Okay, so if I come back here in 5 years, it's going to be the whole room, by the way. We're in the midst of a change. But when I add the medications to the list now, they automatically check interactions. Until that time, and many of you are in the same boat, you have to remember the interactions or look them up. So this was a system change we instituted in my department. We have, in our family practice center, we have 62 providers. So a lot of harm could happen there. So those 62 providers taking care of 15,000 patients now have electronic health records that do things like list the medications correctly, check the dosages, look at the side effects. We do medication reconciliation after they come from the outpatient and inpatient setting. And we have PharmDs who go through and look at some of the medications and some of the medication lists. These are system issues that we improved. Now, it's helpful for every doctor to do better, have their writing be a little clearer, make sure they're spelling the name of the medication correctly, check the dosages. But this is a system change that made a big difference. And I bring this in, this slide. When asked for their ideas on how to overcome the most common medical errors, family physicians offer 228 distinct solutions. And the one that I kind of highlight is 1/3 of solutions for overcoming medical errors were not very helpful, which is doing the same thing but better. I'm going to learn more. I'm going to work harder. My paper lists are going to be a little more evident. And sometimes that's helpful, and it certainly is important. We always have to strive for perfection. But the reality is that making system changes will make bigger differences overall over time. Okay, impact of mistakes, guilt, shame, change habits. It's amazing to see, and I see this now because I supervise so many physicians, how many change their habits after they have a mistake. And this is nurses, this is everyone. They have an error, and from then on, they had someone that they gave them a drug and they didn't do the liver function test. From then on every patient they get liver function tests. And sometimes people call it defensive medicine. I call it error-based medicine. But you leave the evidence behind, because even in my patient that I killed with the inferior MI, statistically they would have had gastroenteritis. I made the mistake that I didn't think about the fatal possibilities. I also didn't think about the language and communication issues. But statistically, one of the times you treat a patient for gastroenteritis, they're going to have an MI. The other is they take less risks. I mentioned the doctor who left internal medicine to go to dermatology. I mentioned the physician who left OB/GYN or just started doing GYN. Some people will move away from taking care of sicker patients or move to areas where the patients are less in need, so they'll be serving an underserved population and go to an overserved populations. And there's whole classes of medical students who have gone through the whole system who then leave medicine and go into something else. So this was a study in Cook County, Illinois, who fought medical liability. 90% of the doctors suffered significant mental effects from the lawsuits. I have actually never been sued. I've had several mean letters written to me. People have yelled at me on occasion. But I've worked with a lot of physicians who have been sued. I write opinions only for physicians. And I see the pain and suffering that they go through. Any of you who have watched or been through a lawsuit know what that's about, whether it's about medical things or other medical things. But this is one of those times. I'm not getting down in the legal system or on lawyers, but physicians don't do well in that system. It doesn't fit in with a sense of who we are. So after the case ended, half stopped offering certain services, 50% dropped certain types of patients, 10% contemplated suicide. This is just after being sued, so this is serious stuff. And I think this was an article in the New York Times, but faced with a growing number of malpractice claims and the rising expectations of patients, a significant number of the nation's doctors have either abandoned the practice of obstetrics or are seriously considering it. This is having national repercussions. My oldest daughter has become a midwife. She actually looked at being an OBGYN and a family doctor, decided it wasn't for her. And in part, when she went to talk to OBGYNs, there was no support in the area where she was looking for continuing to do obstetrics. So we have to somehow remoralize whole groups of physicians and nurses, because the babies are still going to be born. Someone's going to have to deliver them. So just going back to the part, if you've made an error, as difficult as it is, talk to somebody about it. Get some counseling if you need it. Do some CME on the topic. Learn from the episode and move on. So the notion is to forgive and hopefully to be forgiven, but not to forget. So as to make sure that David has enough time to
It's done.
Done. Okay, well, we'll do it in a second. But take just a minute. Turn to the next person next to you. Tell them about a mistake you witnessed or participated in, what happened, who you told, how you felt and feel. So just in this, if you're not in medicine, it can be an error in another area that you've done or you've seen done. So take 2 minutes and talk to the person next to you.
In defense of physicians, Dr. Borkan, number one.
Okay, 30 more seconds. Okay.
You need your water?
Yes, if I could have that one.
Need your cookie?
No, I'll have that afterwards. Okay, thank you. And I'll give some of the results, and I think it was pointed out, in no way do I want to do physician bashing here. This is not about physicians. Errors occur everywhere, and what I'm trying to do, I think, is normalize that if we do things, we're going to make errors. That's part of it. We can improve on it, and we have to deal with it. We have to talk about it. But there's no way that you're going to get through life, and even the next year, without making medical errors of some type. So we're trying to improve system, but we're also trying to deal with it as a reality of our everyday life. And the more you get involved in underserved populations, in new procedures, the more you're going to have side effects. It's part of what's done. There's the old adage, and you may have heard, don't be the when a new medication comes out, if you're a physician, don't be the first physician to use it, and don't be the last. The first ones are going to have more of the side effects, the serious ones, and the last are going to miss it, improving on what happens to their patients. But we're dealing with people. It's an inexact science, as was being mentioned, but so the errors are going to be all around us. So what are the results? And I do this in part just to kind of stimulate the group. And also, this group is going to have to reach a little deeper for their errors. Either that, or if you're the student, you're going to have to cause a few more harm. But how many of you knowingly harmed in serious medical errors? 12 people said 0 errors, so you're in good shape. But that's basically an impossibility if you stay in medicine for more than a week. So get used to it. 2 people mentioned.
So that's because we're first-year med students.
You're the safest ones of all. But the reality is that to keep your kind of ears and eyes open, it's kind of having that third eye that you watch for what's going to happen and happening around. And if you're doing your clinical supervision, do you have that in your first year? Go out and see some shadow people? Okay. Well, so you may not recognize the errors that are happening, but they're happening all around you. It's just part of what happens. It's a complex system with a lot of things happening, a lot of handoffs. How many have died from the errors? Looked as if of those, 11 people said no one died. 1 person said 1, and another person said a few. Okay. And with whom did you discuss these events? No surprises that the majority said no one. 5 said colleague, 3 said a mentor, 3 said family, 1 said a friend, the other said husband and legal. Turns out that spouses, lovers, significant others are often the only ones to hear it, even if they hear it. And did you change your practice because of these errors? 7 said no, 5 said yes. Did you feel you learned something from your errors? 5 said yes. 2 said no, and 1 is unsure. So we did have a fairly small sample in the room, but the reality is that it's happening around you, and if you think prospectively, you're going to pick out a lot more. I'll end just in 1 minute to leave time for discussion. But on purpose, I'm actually a pretty good doctor, I think. I've probably treated 100,000 people over the course of time. But knowing that I have my own little graveyard keeps me humble, keeps me careful, which is something that you asked at the beginning, why are the smarter physicians getting sued more? Well, it may be that over time, the people who are smarter, who did better, are a little less careful. But it doesn't take me out of patient care or teaching. And though I don't see as many patients now as chair, I think that I figured out once that I've seen 100,000 patients, give or take. That's a lot of patients. And I've saved scores of lives. I've been in emergency. I was the emergency services for a large area for 10 years. I've taken care of patients in the hospital, in the ICU, in the CCU. I've saved a lot of people, but I've killed a few along the way. And I just I bring this in because the Institute of Medicine report I personally did not like. I found it to be offensive on all kinds of levels. But it did point out a particular problem, which is we're causing some troubles out there. And the second part of that is to err is human, but to forgive is divine. So the bottom line is learn, then forgive yourself. And it's not just for you, it's your future patients depend on it. So wanted to thank you, and I hope I stimulated some thoughts or comments. So open for questions, comments, thoughts.
First, thank you.
Oh.
We have time for questions. We'll have to actually leave around 1:20 because we have another lecture over at the Rudd Building. But please also remember to repeat the question for the website.
Oh, yes.
As I mentioned, Dr. Borkan, in defense of physicians and healthcare professionals, I told you medicine is not an exact science. Number 2, this is really physician bashing, because if we do this among physicians, we should do it with engineers, architects, accountants. Number 3, every modality in medicine, like for example an appendectomy, has its own mortality and morbidity. It doesn't matter who's doing the procedure. Even the best surgeon can have a complication. Number 4, accidents are supposed to be events that are unforeseen, and if foreseen could have not been prevented. Number 5, you mentioned about the complications there. We forget the fact that all these complications from medical errors add up to healthcare costs, because patients could be admitted to an ICU, or even you have to pay specialists to take care of them. That's one thing bad about medical errors.
Oh no, I mean I actually agree, except physicians do need to talk about it, as do engineers, as do architects, as does everyone. I think that we live in a difficult society because of this issue of responsibility, this linear notion of cause and effect, that if something went wrong, someone must have done something wrong. Which it's much easier to work in other societies where it's all about fate, and so you don't have to worry about anyone blaming anyone about particular events. So it's not like a system that things aren't going to go bad. X number of surgeries have X number of mortality related. You put people to sleep in anesthesia X number of times, some will have complications statistically. Sometimes though, that I think that the part of our own physician culture which has not been healthy is that we have not talked about it, except sometimes in morbidity and mortality rounds, but most things don't get discussed there. The other part is that we haven't improved our systems in a way. So absolutely certain errors are going to happen because it's the risk of a procedure. But not have, let's say at this point in time, that there should be drug-drug interaction that we don't know about is, maybe unconscionable. Why are we still doing, why are we writing 20 prescriptions? I left the country for 10 years. When I came back, people were on double the number of medications. And the old systems were still in place. Well, why is that?
And in one medication alone, there are 20 to 800 steps that in order to prepare the medication.
Oh no, so it's overly, we have a very complicated system, and our systems are often inadequate. But I agree with your points. And so I don't want in any way, shape, or form to think that I'm bashing physicians. I still teach physicians. I still take care. I still make errors. But I think that there's a culture shift that we need to do within our profession that requires a lot more work. One and then two.
Well, I specifically wanted to build off that there's a culture shift. How do you institutionalize that culture shift? How do you encourage it? How do you grow it? How do you take that step from the culture that says, I'm not going to tell anybody about this, I'm going to find my rock, and start building into your processes, into your system? I'm going to help you through this. Mistakes are going to happen. Let's have a plan.
So the question is, what do we do to institute it in our culture? And it's a great question. I think, and I feel like I'm getting old enough now, that when I first started in medicine, we were told to tell our patients when something went wrong. Then there was a time period where we were told, don't tell your patients when something went wrong. And now we're into the period of apology. I don't know, is that reached here, apology? It hasn't quite reached Rhode Island. It's just kind of coming in. But that's something which I think the notion being that becomes a social expectation that if something happens to a patient that's bad, that the most senior person goes in and apologizes to the patient. And that's, and that's whether it's something small or something large.
Supposed to or do is the question.
Well, certainly supposed to, and in some places do. I'd say I mean, it's easy. I'm the chair of the department. I tell people they must do. And our faculty feel that it's important as well. So we have family meetings. And they go in and they tell them what went on, and part of that process is one meeting and then another meeting to process it. So I think this issue, apology, and you can do it in your private life as well, works fairly well, but it certainly in medicine works, is part of, I think, becoming the norm, which is go back to the patient where a mistake was made, say you're sorry, explain all the events, go into detail as much as they want, have a follow-up. And that's actually, it turns out that it decreases malpractice, but it's also very restorative for everyone involved. The other is, and I did this talk in the residency, and the residents' mouths and students kind of dropped open, because here I'm the chair, and I'm talking about people who I've killed. And that's talk about dystonic. They didn't even like hearing about it. But 2 weeks ago, we had 3 deaths in a week. Not all mistakes and errors, but the 2 children and a pregnant woman. And the residents were all involved in every one of the cases, felt terrible. But they actually came back to me and said, you know, about 4 months ago you gave that talk on mistakes. Let's talk about it. So I think it's also, so opening it up. And I think that within whatever school, whatever department, that if people begin to talk more about their mistakes, it'll change. It's also the system change, which is what's happened in the airline industry. It's not just doing better with what you're doing, but saying, we're having some problem with drug-drug interactions, or the same names, or what was happening in our hospital, QD and QOD, we can't use it anymore, QID. The Latin terms have been thrown out because there are too many errors. So it's also changing some of the systems that will make a difference.
Can I just do a brief
Sure.
announcement, because people sometimes have to leave at 1 o'clock. As it's on our new flyers that we now have from now on, that all of our, not only are they mounted on the webpage for the Gies and Stamball lectures, but all of these lectures, the past lectures for both Gies and Stamball, are now freely viewable at iTunes University within the iTunes Store. So if you go to iTunes now, and this is, I give all the credit to Andrew Sinclair, who sits quietly knitting in the back, that if you go to iTunes, into the iTunes University tab and search for Louisville Bioethics, you will see all of our outstanding speakers for both the Gies and Stamball lecture series, as well as for the new Chang lecture, which will be on May 11th, as well as Howard Brody, who's going to be speaking on May 10th. We have sort of a mini festival in ethics for May 10th and 11th for those of you who will be here. Thank you.
I have to comment on one slide, the top line. On every U of L ad for the last year, it says, it's happening here.
It does say that.
U of L's current model, it's happening here. Well, not only does shit happen, but it's happening here. You mentioned being...
Can you summarize that?
I like that.
You didn't mention the worst thing. If somebody dies, that's negligent homicide. That's manslaughter. That's felony. You've got a zealous prosecutor, and that can be a problem. The thing I wanted to ask about was professional standing. If you talk to people about what you do, are you going to lose privileges? Are you going to lose your license? If you talk to the risk manager at the hospital, and the risk manager talks to the chief of staff and says, do we want him on our staff anymore? Is the hospital exposed to too much liability? How does this affect your career? I think you gave a good presentation. It shouldn't if you knew all about it, but does it, in fact, jeopardize your career?
No, it's an excellent question. And I don't have all the answers. Also, I think it's state by state. But in Rhode Island, we may have seen that we were known for many things, some good, some not so good. We're the Ocean State. We're also the state of wrong side surgery. Did anyone follow that? So turns out that especially the neurosurgeons had a series of cases where they operated on the wrong side. Now, it turns out that probably isn't more than the national average. But it was publicized. It got to the Department of Health. And the physician who was involved, the #1 physician, can't get privileges anywhere. But so I think that in that extreme case, yeah, it can have an effect. But that physician, what was looked at for that particular physician was his pattern of errors, whether he improved between cases. It was the same physician who was made one case after another case after another case. Now, he had many cases where he figured out the right side of the patient, but too many errors of the particular type. In general, however, and once again, patients do die, but most errors don't result in death. If they're dealt with I know within our educational system, within the residency, no, it doesn't affect as long as we feel that the person has done some remediation. In fact, at least in our setting, we tell people that you're a resident, that's the time you're supposed to make mistakes. And we hope that most of the mistakes are picked up or corrected before they affect patients, but they don't always. So in general, no, but I think that people who do have a pattern of errors that repeat, have some issues. And I think it's gotten better, but for a while, as I'm sure you know, that obstetricians who had multiple cases, malpractice cases against them, had a difficult time getting malpractice insurance. That being said, I think you well know that most errors do not result in malpractice cases. As I mentioned, I've killed several people and lots of errors. I've never been sued. I may still be sued sometime, but I have tended to take care of people who are poor and underserved who have tended not to sue, or we've dealt with it in ways that that people felt that they were rectified without going through the court system. So by and large, I do want to make one very clear thing, that making errors is not the same thing as being sued. But I think that if you do make errors, I think that most medical staffs are hoping that you will learn from them and not repeat them.
Do you ever participate as an expert witness in medical malpractice cases, or would you recommend that to somebody as part of the process?
It's a good question. This question was, would you be an expert witness? And this may or may not be fair, but in terms of the ethics of my own department, I had a situation that happened as I came back to this country to become chair, that a friend of mine who became a family doctor at my medical school had been sued by a patient. The patient had chest pain. He sent the patient off for a stress EKG. Treadmill was done, read by the cardiologist as normal. Came back to the family doctor. He looked at the treadmill. He said, "It's normal. You're fine." Patient went out and had a heart attack. They had an expert witness for the plaintiff read the stress test. It was misread. The cardiologist had misread it. The person sued both the cardiologist and the family doctor, and a fairly well-known professor of family medicine testified as an expert witness for the patient that the family doctor should have known. He should have been able to interpret the stress EKG, and that was part of routine practice of family medicine, which I thought was both absurd and also that he was using his academic title to assist. So I both talked to the chair of that particular department, as well as made a rule in my department: you can't write anything for patients. Now, that's not fair on a wide level, because we need to protect patients. I just felt that at this particular time in history, it's tough enough to be a family doctor in primary care, that being an expert witness for plaintiffs, I didn't want that to be part of our department. I do allow people in my department to be expert witnesses for physicians. And that's, I think that was really a judgment call on my part about the state of family medicine, the state of primary care, the state of the difficulty at this time. But
if you get sued as an expert witness, you have to pay your own. You are not covered by anything. You are not covered by your malpractice insurance, because it has nothing to do with your clinical responsibility.
So there is a risk. Absolutely.
But as I mentioned to the medical students, I emphasize your health to your standard. The law doesn't set the standard. Your health to a standard of care, and it's what your peers do. So if you don't get an expert witness, your expert witness establishes whether or not you did what a good physician in this area would do. That's the standard you're held to. So I think medicine sets its own standard.
Oh, yes. I mean, and I don't think I want to. So the question is about the standard of care, and standard of care is very different from evidence-based medicine, by and large. And having worked now in 7 different places, I'm always amazed at what's the difference between the standard of care. And so as many things. I'm an anthropologist. It's not about truth. It's about interpretation. So I'm very impressed that interpretation varies from place to place, from moment to moment. And so in some ways, it's a slippery slope, which is one of the reasons why physicians have such a difficult time in the courts. Is it's a different way of thinking and living and talking. But I'm more concerned about what happens to patients, what happens to systems, and what happens to the doctors or the young doctors. Because I think you need to be able to decide your career without worrying about. I always tell students and residents, choose what you're passionate about, not how much it pays, not how often you're going to be sued, not the risk. You need to go into things and realize. And I think, as the physician was here was saying, it all involves risk, and errors are going to be made. Any other questions or comments?
A lot of us in this room are medical students, and I guess I'm interested in, with this fear of making these mistakes, this fear of being sued, how do we keep the costs down? Because you're afraid of being sued, you want to refer them out to somebody else that knows more about it to take care of it. So how do we keep that cost down and kind of equal out the fear versus the cost of medicine for everyone.
So I'm repeating for the online, but how do we keep the costs down if we're basically practicing defensive medicine and trying to be able to do the things? I mean, it's a great question, and I think it's difficult. On one hand, it's making the risk, the fear of making errors. I think to have that in the back of your mind, not necessarily in the front, is always a good thing because it keeps you careful. And if you see, both myself, you watch physicians who practice, they get into trouble when they work too fast, become too careless, become too cocky. So the notion that I always tell the residents to do is think about what's common and think a little bit about what could kill the patient. So when you see that patient with X, Y, or Z, what serious thing might they have? So if you consider it, it'll actually reduce the risk. The testing may or may not reduce the risk. The referring out may or may not reduce the risk. And how do you do it cost effective? Well, one of the ways in family medicine, someone has heart disease, serious heart disease, I'll send them to see the cardiologist once a year, once every 6 months, not every month. I won't do testing more than what are specific averages that are required. And when you send more tests, you actually get more abnormal results. 5% of tests give abnormal results. So you end up chasing your tail and creating more problem, not necessarily creating health. So I think it's a discussion that's important, but if you see what happens is like the physicians who make an error because they didn't order a test and then order it on everyone, you actually can go back to things like the U.S. Preventive Health Task Force and say, these are evidence-based approaches to problem X, Y, or Z. But I think that's why being humble by being careful is important. Testing more isn't necessarily the way out of it, though some people find it. I don't know if...
And I was going to, you did that perfectly timed, because what I was going to say is the same thing, is that the evidence-based medicine and the U.S. Preventive Task Force helps a lot for primary care as well as for secondary care physicians. If a patient comes in saying, I want an MRI because I've got a headache, that doesn't mean you have to go ahead and order it. If it is the worst headache they've ever had in their life and you're worried about a subarachnoid hemorrhage, well then maybe you may think about it. But if it's the same muscular contraction headache that they've had for the last 20 years, probably not. If the patient comes in saying, I'd like you to check my PSA when they have no risk factors and no symptoms, then you may want to go ahead and talk to them about the wisdom of doing PSA testing. If on the other hand you then do that PSA and it's now, let's say, up slightly elevated at 6, and you go, oh, well now we better go ahead and do an ultrasound. Well, there's positive for a possible shadow. Well, then we better go ahead and do a series of, let's say, 15 to 20 little pinpricks with a needle through your rectum into that prostate. You may then start asking that patient afterwards, so how much harm was there in all the testing that we just did from that one blood test? And it can cascade into a series of things where people are chasing phantomonas, where they think there's maybe a possible GI cyst or heart tumor, or a brain cyst or heart tumor that get chased for a variety of reasons, and then bad effects occur. So bad things do happen when you chase things, and there's not an evidence-based reason for doing it, or a symptom to show that you needed to be hunting for it.
That's an extra, because we are causing harm and sometimes death through our workups. The other piece is, and it's important in all of medicine, is to be comfortable with uncertainty. And now tomorrow the sun's going to rise, but you don't know what kind of day you're going to have. If you're a person that needs absolute certainty, go into certain fields. If you're one who can to teach yourself to learn with uncertainty, to be comfortable with uncertainty, is really important, because we can't be certain about everything we do. So we have to live with a bit of risk. And the other key thing is, rather than testing, at least in family medicine, we see the patient back. Why don't you come back in a day? Why don't you come back in a week? Why don't you come back in 3 months? Let's see how things are going.
So Benjamin Franklin said the only two things that are certain are death and taxes.
But uncertainty is important. Any other questions? But a good question. And it's something you'll struggle with forever. Turns out that if you look at physician testing patterns, that they are not at all correlated to quality, which is the other piece. But okay, well, thank you very much. Good luck.